Good morning, everyone, and welcome to our Pediatric COVID WebEx. Believe it or not, it is July, and we are thrilled to have each of you on the line. We're particularly grateful to have Dr. Andy Pavia with us, the George and Esther Gross Professor, Chief Division of Pediatric Infectious Disease, Director of Hospital Epidemiology at Primary Children's, and just a longtime pillar in our community of pediatrics. So Andy, it's a privilege to have you with us, so thank you in advance here. As a reminder to everyone, we will take questions through the chat function. So if you hover your mouse down on the bottom of the screen, you'll see a voice cloud, and that's where we can take questions. We will have a time partway through the presentation to pause and answer some questions before moving to the end, where we'll have time for more questions as well. Our team will track those questions, and even if we don't get a chance to answer them directly here, we'll try and get information back on your questions. So Andy, without further of my rambling on here, let me pass this off to you. Again, really appreciate you presenting today.
Well, thanks, Neil. Thanks for having me, and thanks for everyone for everything you do and for getting up early to listen to me ramble on. What I'm going to do this morning at this kind of crucial time where things are changing is I'm going to review the epidemiology, drill down a little bit with a focus on children, then just touch on some new clinical data that I think you'll find interesting, take a break, and then we'll talk about the prospects for vaccines and where we stand in this ever-changing environment. And I put my Twitter handle up there. You know, I'm trying to enter the modern world, but I found Twitter to be useful at a time like this. For those of you who follow the epidemiology really closely, I apologize if there's any repetition, but I think it's really important to go over this in some detail. We're at an inflection point. Unlike countries in the European Union, the United States enjoyed a brief plateau, but is having a resurgence. The first surge has never ended. It's at an all-time high with about 44,000 new cases a day. The glimmer of good news is that the death toll is not going to commensurately. This, in part, I think, reflects the fact that our hospitals and our doctors are learning on the job and doing a much better job. Our hospitals are not as overwhelmed. And as I'll show you in a minute, some changes in the epidemiology. So where's it happening? A few weeks ago, we talked about 3 states or 4 states that were leading the way, but now it's really spread throughout the country. This is a heat map from CDC with red, orange, and yellow depicting different relative high growth rates per 100,000 persons in the last 14 days. And you can see that a disturbing amount of the South and the Southwest is in red. And you can, if you drill down to Utah, you see that many counties in Utah are in red and most of the remainder are in orange. Let's look a little bit at our neighborhood. It's my clumsy attempt to show the 4 corner states there and the epi curves for each of the 4 corner states. And you can see that we have this marked increase curve. It's not nearly as bad as Arizona, which has hit about 74,000 cases as of yesterday. Idaho is having a resurgence as well, although their absolute numbers are much, much smaller than ours. The contrast that I think is really important and that we should take to heart is between Utah and Colorado. We peaked at a lower level in Utah than they did in Colorado. They had an early peak with over 100 new cases a day, but they are declining and now having a modest upswing as opposed to our dramatic increase. And we don't know all of the things that are directly responsible for that, but there are a few major differences. Colorado opened slowly and cautiously. We did it sort of rambunctiously. Colorado allowed municipalities to require masks. We did not until last week, and that probably accounts for some of the differences. This is the epi curve for cases per day in Utah. You've all seen this. It's in the paper every day. But what I wanted to superimpose on it, just so you get some sense of the time frame, is the stages of the reopening. And you can see that at the time of the reopening, we were not in a decline. We were in a relatively stable to slightly increasing uptick. And I have to point out that's in contrast to what the governor's plan was for going to orange. It was supposed to be 14 days of steady decline. When we went to yellow on May 16th, things remained stable for a little while and then started a dramatic uptick. The red arrow shows you Memorial Day. And about 7 days after Memorial Day, the wheels came off the bus. And we have gone from a median of 145 cases per day at the time we began the reopening to 554 cases as a 14-day moving average, rather 7-day moving average. So we're in trouble. Who's getting sick? Well, if you look at the cumulative cases and incidents, cases numbers are in the blue bars, and you see this predominance of cases in people 25 to 44, but these are uneven intervals. So if you look at the incidence, you see that it's pretty similar for children less than 1, maybe a titch higher than children 1 to 14. Then it goes up dramatically in 15 to 24 and in 25 to 44-year-olds. But that's cumulative. That's the picture from the beginning of the epidemic. Keegan McCaffrey at State Health Department has started to plot the epidemic curves by age group, and he shared these with me. And to orange, as you go across the top, there's the age groups 0 to 1, 1 to 14, and 15 to 24. And what you can see very clearly is that young teenagers and young adults, 15 to 24, 25 to 44, and perhaps middle-aged adults, 45 to 64, are where the surge is happening. There's relative stability among older adults, probably reflecting where the changes in behavior have been most dramatic. And as has been pointed out many times, most recently by Tony Fauci yesterday, disease in young people doesn't stay in young people. If you have huge amounts of disease circulating in young populations, it's going to infect children, it's going to involve pregnant women and the vulnerable. So let me change gears just a minute to talk about a few things that we've learned in the last month or so about children. We still have unanswered questions, but there was an early suspicion that kids were less likely to be infected. And it was unclear until recently whether that was because schools closed early and there was stay-at-home orders, or whether it might have been a true intrinsic characteristic of children. And it's becoming increasingly clear that children are more difficult to infect with COVID-19. This is an important paper in Nature Medicine. They used modeling, and they looked at data from China, Italy, Singapore, Japan, Canada, and South Korea. So very disparate countries with different school closings, different lockdown periods. And they used modeling to estimate the susceptibility of children compared to adults in different age groups, and concluded that children less than 20 were half as susceptible to becoming infected as those greater than 20. And more importantly, perhaps, there was a much greater proportion of asymptomatic or mildly symptomatic disease in younger people. 79% of those who were less than 20 were asymptomatic or polysymptomatic, and therefore likely to be undetected. Now, this doesn't tell us how infectious children are to adults, and there the data are less clear, but a number of household studies are suggesting that in contrast to influenza and RSV, children are not super spreaders to adults. They are infectious, but it appears that adult-to-adult transmission is more efficient than child-to-adult transmission. And why that is, we don't know. We can speculate on that and talk about that a bit. And what you see below is the modeling curves that just show the likelihood of infection by age group using the data separately for each of the 8 countries to show that at least in this model, it's robust and consistent. So kids are harder to infect and maybe a little bit less likely to transmit. The other area where I think the data are becoming a little bit more clear is on the range of severity. We had to rely early on case series from China, which were very large, but it was unclear how they really could be generalized to European and US settings. And so now we have more data from American cohorts. There's a big one from CDC, which you may have already seen, but just recently released is one from the network that is centered around CHOP in Philadelphia. So It's the network. It doesn't just include inner city Philadelphia, but it includes a lot of suburban population. So it's a fairly balanced population. And this is one of the largest series in in the West that's been reported. They reported on 7,256 children who were tested. They found 424 were positive, pretty low positivity rate. Interestingly, about 43% had no comorbidities. About 57% did. The most common comorbidity, not surprisingly, was asthma, but the next most common was obesity. And this has shown up in a variety of other studies. So obesity in children, not just in adults, is a risk factor for getting infected and for severity. Of their 424 kids, about 18% were hospitalized. That's not too different than it is in adults. We typically quote about 20 to 22%. Remember, there is a large proportion of kids from disadvantaged households in this population. But of those who were hospitalized, only 3% needed any form of respiratory support and 1.5% were intubated. That compares to about 5% for adults. So decreased severity even among those who were hospitalized. 2 went on to ECMO, and there were 2 deaths. So about a 0.05% mortality, less than in adults. But it's important to realize that kids can die of COVID-19. And we've talked in this meeting a fair bit about MISC, so I'm not going to belabor it, except to point you to 2 important studies that I think are worth giving a scan to. They were published online 2 days ago in New England Journal. One is a case series from CDC that involves 186 children in 26 states, including several kids from Utah. Of the kids with MISC, 73% were previously healthy. One of the nice things about the CDC series is they were able to identify a small number of kids who could define the time at which they had COVID-19 disease and then track the time between disease and developing MISC. And the median was 25 days with a range from 6 to 51. And if you look down to the lower right-hand corner of the slide, I don't know if you can see my pointer, but this is from the New York City data, and you see the epidemic curve in the red line of cases among children, and then the epidemic curve shifted to the right of cases of MIS-C, showing that it really is a post-infectious phenomenon that occurs weeks later. The implication for us is that we're just about 2 to 3 weeks into our surge. We did admit a kid with MISC at the end of last week, and we're worried that we will see more lagging behind the spread of disease. So the other study was from New York State. They reviewed about 190 patients, 95 were considered confirmed. Again, 62% were previously healthy children. And one of the interesting things to point out from that study that's different than what we knew before is they were able to estimate incidence. So there were about 2 cases per 100,000 persons less than 21 with MIS-C, compared to about 322 per 100,000 for COVID-19 disease diagnosed by PCR. So the rate is perhaps in the range of 6 per 1,000 cases of COVID-19 may develop MIS-C based on this estimate. The other thing they did that's kind of fun is they correlated symptoms to show how they went together in this diagram here. I don't expect you to read it, but what a point is that these 2 predominant symptoms are cardiac involvement and gastrointestinal involvement. About 80% of the kids with MIS-C present with initially GI symptoms. So when we're thinking about whether or not to entertain that, that should be one of the triggers, several days of unexplained abdominal pain. And as promised, I'm going to pause there and see if anyone wants to talk about epidemiology before we go on to talk about vaccine.
So Andy, I haven't seen any new questions pop up in the chat box. So just a reminder to folks, as you have questions, please feel free to enter them in. So Andy, I just wanted to clarify that last point. The audio cut out just a little bit, or it was just a little fuzzy. You're saying the point about the abdominal pain. Can you repeat that one more time?
Yeah, so the number one symptom for children who went on to be diagnosed with MIS-C was abdominal pain. More than 80% had it as their presenting symptom. So you then progress often to shock. Sometimes there are the Kawasaki's-like findings of swollen hands, rash, and conjunctivitis. But cardiac involvement is the next most common feature because eventually that was diagnosed in about 70% in the New York series and pretty similar in the CDC series. So prolonged, several days of abdominal pain without a source, that appendicitis workup that isn't appendicitis in a child who's got fever and is starting to get sicker, we really ought to be thinking about MIS-C as a possible diagnosis.
Great, thank you. I have a couple questions to cover here before we go on now, Andy, if that's okay. From Tim Larson in St. George, is decreasing death rate due to younger age of newly infected people as the economy opens, or better healthcare? So
I think the answer, it's a great question. I think the answer is yes, there's evidence to support parts of both. The mortality for people admitted to ICU has been falling, and it appears that if you age adjust, it's still falling. It's probably due to better basics, supportive critical care, combined now perhaps with the beginnings of the use of dexamethasone and remdesivir to help with that. But we've been seeing mortality improve regardless of the age of people admitted. But with this very dramatic shift to younger people being infected, they are being hospitalized at pretty decent rates, but they tend to survive. So the mortality drops off even more rapidly. And I didn't go over that again because I think I've shown that to you before as you look at younger age groups.
great question, Tim. We have a note here, Andy, from Bridget. If you're a little closer to the microphone, it might help the occasional breaking up of the sound. And just a little pass that along. And then Jennifer Brinton asked the question, are we seeing minority children more involved like we are with adults?
It's a great question, Jennifer. Absolutely. In Utah and in the western states, Hispanic children are several times more likely to be diagnosed with infection than are white kids. In the East, it's both African American and Latinx kids who are more likely to be infected and hospitalized. In a series from Children's National, Black children were more likely to end up in the ICU than were white children, and probably reflects, as everyone knows, the disparities in healthcare and socioeconomic status. There, what I didn't mention, I was going to show, but I took out in the interest of time, is this appears to be true for MIS-C. We don't know yet whether once infected children of color are more likely to get MIS-C. More likely, it's just that they are more likely to become infected and therefore more likely to develop MIS-C. But it's an unresolved question.
Great. Thank you, Andy. Those are the, let's do one more question here and then feel free to move forward with the next section. From Stephen Aird, are there any new estimates of actual prevalence based on serology studies?
Yes, very good question. So CDC released the results of serology studies that were done in a convenience manner. They took discarded serum samples from Quest and LabCorp. So these were healthcare. And they just published their results in MMWR. Well, they didn't actually publish the results. They have an online webpage. And in general, what they estimated was that we're about 10 infections diagnosed by serology compared to for every one that was diagnosed by PCR. But this is a convenient sample of people who were tested without much other information about them. So it's clearly biased towards some degree of higher likelihood of being infected. So we have an estimate of how biased it is because in Utah, we just reported out a study which is called the HERO study, which was a systematically cluster sampled serosurvey done in 4 counties in Utah: Davis, Salt Lake, Utah and Park City. And we did a number of statistical corrections to look at sensitivity, specificity, and the sampling frame. So this was probably more rigorous than the CDC studies in several ways. We estimated for Utah that there was about a 1% overall seroprevalence, and the CDC estimate so we had about 8,000 samples, CDC had 1,000. They got an estimate of 2% seroprevalence. Now, the confidence intervals actually overlap because of the small size of the CDC study, but it suggests that the 10-to-1 is probably a high estimate, but it is clear that we are markedly underestimating the total number of cases if we use serology. Long answer, sorry.
Perfect, great. Andy, if you want to move forward with the presentation, we have another good question from Roland Dimmick that we'll come to at the end here as well.
Okay, I will try and give you an overview of vaccines. It's something we really should come back to frequently. Some of you may have heard me talk about this at the Intermountain Leadership talk about a couple weeks ago. There's a little bit to add, but not a lot. So this is a really high stakes game. There are 140 vaccines in development that we know about. This has become a frequent topic of financial newspapers. This is from the Motley Fool, showing the real stakes that are not just lives, but could be billions of dollars for some of the companies that are involved. Here are some of the companies that are involved, but I show this also to show some of the big players because this is very important. NIH is heavily involved. I'll talk more about that. Bill and Melinda Gates, CEPI, which is the Center for Epidemic Preparedness and Vaccine, Gavi, the Global Alliance for Vaccine Innovation, and other nonprofits are involved. And you can see the name of several universities here. Now, this is just a small smattering of who's involved. But I want to go back to a little bit of the basic biology because it's important when we think about what vaccines are aiming to do, how immunity might protect us. This triangle here is a representation of the spike protein that you've heard so much about. And what's important about spike protein is not just this green area here, the receptor binding domain, which is where antibodies that we can most easily identify as neutralizing antibodies bind, but also this trimer here, which is the fusion domain. And why that's important is for two reasons. One is that the fusion domain acts as a syringe. It shortens and injects the virus into the cell membrane, as shown here, and allows it to fuse and the virus to enter a vesicle. So there may be other neutralizing domains on the fusion molecule, but those have been difficult to model and not clearly understood. The other is that depending on how you manipulate the protein in the lab, it can be in very different three-dimensional formulations. So you run the risk of creating antibodies that are not functional. And more than not functional, they could even be harmful. There are a lot of special issues that make developing a SARS-CoV vaccine challenging relative to other vaccines. I'll go over a couple of those. First, we don't have a terrific understanding of the correlates of protective immunity. We know that there are neutralizing antibodies generated by natural infection. In rhesus macaques, they're protective. We obviously have not done human rechallenge studies, so we don't know. But in macaques and in humans who recover, the T-cell response, particularly the CD4 response, seems to be very, very important. And part of the issue there is that it's much more complex to measure CD4 responses in the setting of a vaccine trial. It's doable. There are many assays that we can develop to do it, tetramers and others, but it's more expensive and they're not standardized. The other issue with any vaccine is how do you design the trial endpoints? Do you want to prevent any infection by seeing anybody who's PCR positive, whether symptomatic or asymptomatic? Do you want to protect against PCR-confirmed disease? Or will you settle for protecting against severe disease and keeping people out of the hospital and protecting them from dying? But whatever endpoint we use, the phase 3 studies it's estimated need a sample size of about 30,000 participants. And that's going to depend a little bit on where you do your trial. You do a trial in a place where the infection is raging, like Utah or Arizona right now, you'll reach your endpoint sooner than if you do it in a place like New York, which now has a relatively low attack rate. So it's going to be challenging to figure out where to put the trials because you have to predict where the disease is going to be in 2 to 3 months. The other, one of the other things about immunity is we know that natural immunity appears to fade fairly quickly. This is an important new paper by Long from Nature Medicine. And in the bottom, you're seeing the decline in antibody titers over a fairly short period of 4 to 8 weeks. So both neutralizing and IgG antibodies are fading fairly quickly. But up top, you see something else that's important. People who are asymptomatic tend to have lower antibody titers, shown here in green, compared to people who have more severe disease. And that has two implications. One is it means that people with mild or asymptomatic infection may become susceptible again. And it means that it may be challenging to develop durable, potent immunity with vaccines. So just because we can measure some degree of antibody conversion doesn't necessarily mean that we've gotten an effective antibody. One of the other challenges is that the immune response to SARS-CoV-2 is at the same time your friend as your enemy. This is a complicated cartoon, but the point of it is that if you look at what happens after virus entry into the cell, the immune response that you develop through the innate immune system and the adaptive immune system can trigger the cytokine storm that leads to a lot of cellular damage, and at the same time trigger protective immunity through CD4 cells, CD8 cells, which will kill infected cells, as well as neutralizing antibody. What else is difficult about making a SARS-CoV vaccine? Well, it needs to work in those who generally don't get good vaccine responses, people with underlying conditions and the elderly. It needs to provide herd protection around the world. And we don't really know what level of efficacy times coverage will be needed for herd protection. There's a paper that just came out that Tony Fauci quoted yesterday that estimates that the target should be about 75% efficacy if we are only expecting to get 60 to 75% vaccine coverage. And that should give us some element of herd immunity. There's the need for speed. We are in an unprecedented crisis. But with that, we have to think about the potential risks associated with the vaccine and making a safe vaccine. And it's particularly important with this virus because of the immune potentiation that occurs. And it can occur through two mechanisms, vaccine-enhanced respiratory disease and what's called ADA, or antibody-dependent enhancement. Those of you old enough to remember the original RSV vaccine, it was a great example of antibody-dependent enhancement that made the disease actually worse. If you want to read more about it, Barney Graham's article in Science is really good. Most of the vaccine candidates are probably going to require 2 doses. That's going to make the logistics much more difficulty. And then the scalability here is absolutely staggering. This disease is affecting the entire planet. We've got 7 billion people who might need 2 doses. And how do we do that equitably, fairly, quickly, and affordably? And then there's a final challenge that may be our biggest one in the United States, and that's anti-vaccine and anti-science sentiment. As she said, there's a general anti-authority and anti-vaccine feeling among some people in the country. And if we can't get decent levels of coverage, we're not likely to get good levels of herd immunity. I want to show you some of the candidates in a minute. So I thought it'd be worth just talking about what kind of platforms we're talking about. DNA vaccines have to get DNA into cells where they can replicate. RNA vaccines can either be mRNA, which will begin replicating itself, or a replicating RNA vector. Neither of these have really ever proven to have a safe and effective vaccine out there in the world. They're moderately scalable, but they're very fast to develop. There are non-replicating and replicating viral vectors. We have examples of successful vaccines that have been developed this way. And once these are working, they're pretty easy to produce in large bulk. So that's kind of exciting. Protein subunit vaccines, we've got a lot of experience with, and inactivated vaccines and live attenuated vaccines, got a lot of experience with. But really of these, only live attenuated vaccines typically require only one dose. I thank Kathy Newsel, whose slide I stole for this purpose. But Kathy's always sending me great slides. So there are 140 candidates, and I'm going to put you to sleep by going through all 140. No, really, I won't. I'm just going to focus on some that are in clinical trials and some of the top candidates that are about to enter trials. So you may have read that the US government has picked 5 candidate vaccines for what they're calling Project Warp Speed. And these are the vaccines that are going to be supported through an NIH mechanism of trial support. The one that you may have heard the most about is the Moderna vaccine. This was initially developed with NIAID money. It's an mRNA vaccine. It's just entered combined phase 2/3 study. So it's currently undergoing phase 2, but it will transition seamlessly to phase 3. The Pfizer vaccine is another mRNA vaccine, slightly different approach. It's in phase 1. It's also in the warp speed. Inovio, which I'm going to talk about since they just announced some results, as a DNA vaccine in phase 1. The one that's farthest along in development is the Oxford vaccine, which is now being commercialized by AstraZeneca. It uses a chimpanzee adenovirus. So it's a non-human adenovirus that's replication deficient. It is a really interesting vaccine candidate. There are no other examples of this one having been brought completely to market, but there are a number of other vaccine candidates. Also on this page, I want to point out the Ad5, adenovirus 5 vaccine by CanSino Biologics, because this is the only one that has published data. Everything else only has press releases on their human efficacy. There was just an announcement yesterday that the Chinese military is going to be given this vaccine, even though it has not started phase 3 studies elsewhere. And it wasn't clear that the Chinese military was going to get it in the context of a trial. They were just going to get it. Other candidates are listed here. They include, some are inactivated virus with adjuvant, inactivated virus, and protein subunit nanoparticles that are in human trials right now. These are some of the other exciting candidates that I've picked out. 2 are supported by warp speed. The Merck vaccine, which uses the secure stomatitis virus backbone. This is the backbone that created the incredibly effective Ebola vaccine. It's about 95% effective or efficacious in the field with Ebola. So it's kind of an exciting one based on its previous track record. Johnson & Johnson has an adeno-26 virus vaccine. Novartis has an adeno-associated virus that people are quite excited about. And then there's some other candidates. The one I think is most interesting is the skin patch with micro needles being developed by Pitcovac that doesn't require injection and induces some unusual immunologic characteristics because of the way it gets into the epidermis. So how's NIH going to make this move forward? They've announced this active model for vaccine development that is really just a way of boosting the resources available to each of the 5 vaccines they're supporting. So they've picked their 5. I showed them to you. They're going to harmonize the design and the step down of the efficacy trials. They'll use collaborating clinical trial networks, and most importantly, they're going to develop the lab assays at NIH and use these to support across vaccines, as well as having statistical supports, standardizing some of the statistical methods, and the data safety review. So this is the one and only actual published preliminary results on first-in-human studies. This is the Chinese adenovirus 5-vectored vaccine, and it was published in Lancet. I won't belabor this table here, but what it shows is that at the 3 doses, you got increasing levels of antibody response. They did demonstrate neutralizing antibody, which we think is better correlative protection. They mentioned in the article that there were some T cell responses, although the number of assays that they report on was relatively small. But importantly, they saw something that we've seen with other adenovirus 5 type vaccines, and that is that if the person had neutralizing antibody to adenovirus 5, they tended not to respond to this vaccine. So the backbone virus had to be able to replicate in order to get a good response. It was fairly reactogenic. 42% got fever even in the low dose, and injection site pain was 47%, and it went up with dose. But still, preliminary, interesting, and promising results. All of the rest of the efficacy data we have to date is by press release. This is sort of the bane of this epidemic, is that we're getting science by press release. Over a month ago, Moderna announced positive results from their phase 1 trial. They actually only reported on 8 patients who developed neutralizing antibody. They were pretty roundly criticized, even by their sponsors, NIH, for science by press release. And unfortunately, we have not seen an article in press or out for preprint on this one, but that's what we know about it. And then just yesterday, Inovio announced positive interim phase 1 data for their vaccine, but there's even less detail and specificity in this press release. These are, I think, larger gains for the investors, and unfortunately, it does not give us as scientists a chance to look at the data. In the last couple of minutes, I want to talk about some of the broader ethical issues, if you will, about SARS-CoV vaccines. So what about children? Usually you want to move quickly to a step-down trial. As soon as you get phase 2 safety and efficacy data in adults, you want to involve children, usually in decreasing age cohorts. And that's probably a good thing. Efficacy trials, when they're done in children, will be harder and need to be larger, so we'll need good immunologic surrogates. But how comfortable are we with vaccinating kids knowing that there is the risk of MIS-C out there? We just don't know. But we're going to have to balance the fact that children are less likely to be infected, but getting immunity in children will probably be really important to develop community protection, and because of the small number of children who do end up getting critically ill. And in order to know how important that is, we're going to need to know whether a vaccine prevents shedding. Because if it doesn't prevent shedding, but just prevents symptomatic disease, then vaccinating children is a different calculus. So who's first in line? How are we going to prioritize vaccines? So I was involved in 2003 through 2005 in an extensive NVAC effort to figure out how we would do this for flu vaccines. And that framework has really carried forward. ACIP has a work group to think about prioritization. I'm not on that, but this is what they've put out for their prioritization process as they think through it. They need to think about the influenza framework as a jumping off part. They're going to think about evidence of efficacy, where the burden is, where the benefits and harms are, and the acceptability, and then have to balance that with the ethics and equity principles. Some of these decisions are pretty easy. Caregivers on the front lines are going to need to be first in line because society really depends on that medical response. But after you get through the easy part, medical providers, first responders, then it gets tricky. And at some point, we'll come back and talk about that in more detail, maybe as we get closer. So final slide, take homes. There are many vaccine candidates out there, and the effort to develop vaccines is really massive. But so far, we don't really have strong signals even that we're on the right track. Production, I didn't talk about, but that's a huge challenge. Distribution is a huge challenge. It's very likely that we will not have enough to go around, so we're going to be in a situation where prioritization is important. I think confidence and trust in vaccines is critical, and the time to work on developing that is really now. if we want people to be ready and willing to get vaccinated, Lord willing, and the creek don't rise in January and February of 2021. Those dates are obviously aspirational. And there's a lot of misinformation out there that needs to be combated. I like to quote Tony Fauci whenever I can, just because he's another Italian kid from New York, and maybe knows a bit more than I do about all this stuff. He says, it isn't over yet. Well, I probably would have said it ain't over yet. I act optimistic, but deep down, I do everything I possibly can, assuming the worst will happen, and I have to stop the worst from happening. Unfortunately, I think we are moving towards the worst right now. I'm cautiously optimistic that we can find the political courage and change behavior enough to turn things around this summer, but we have a long way to go. And it's probably won't be the last time we're talking about this. So I'm going to stop there.
Great.
Thanks for your attention.
Well, Andy, this was wonderful and really illuminating. I'm going to go in order of the questions here just for a few minutes until 8 o'clock, then we'll wrap things up. So from Roland Dimmick, this is touching on what you were just talking about. He said, obviously school closures were crucial in controlling the spread of the disease. As we look to the fall, do you have an opinion/data to guide the decision for families asking about return to preschool and school? And I might add that the AAP put out a statement that I read recently, I believe, strongly advocating for school. But what are your thoughts there?
It's a great question. I'll try and make it a short answer. I think we all know it's good for kids to get back to school, and that's really what we want to do. And we know that it's relatively safer for them compared to adults. It's probably an easier decision in preschool than it is as you get towards high school because the risk of disease goes up. I think that the default position is we want to open the schools. We're going to learn a lot from what's going on in Asia and Europe, but I don't think we can do it if our curves look like they do today. I think it's really going to be dependent on our turning the rates around if we want to open schools in August. I think that's one of the best economic arguments is if we can't turn things around in July, we can't open the schools in August safely.
Great. And then a question that you touched on a little bit already from Rachel Barr, could immune potentiation potentially trigger MISC in children who receive the vaccine? And then I'm going to throw in a related question from Joseph Johnson. He asked if they've seen any MISC type illness in adults. So first the vaccine question and then the adult question.
So that's a theoretic concern, Rachel, that we're obviously really worried about. Unfortunately, we don't know which antigen triggers MISC through what pathway or if there's genetic predisposition. So it's going to be hard to predict for vaccines. Best guess is that we're going to have to watch for it as a very rare and possibly genetic predetermined side effect, depending on what vaccine we use. And then as for MIC in adults, there are cases in young adults up to, I think the oldest I've heard about is about 25 that have been identified that clearly follow an MISC pattern. But of course, we would probably have difficulty diagnosing it in an adult because if it looks like Kawasaki's, the average internist, and I say that as a med-peds person, won't recognize it.
Great. So then a real pragmatic question from Joseph Johnson, and I think this is something we all get. He says, I get questions every day like, what should I do with my child regarding being around others, doing their sports or other activities? With so much spread right now, how would you answer this question now and going forward?
It's so hard. We need to explain to people that the risk of specific activities is the risk of that activity times the risk in the community. So what was safe to do a month ago when there wasn't that much disease in the community is riskier now because there's so much more of it. We know what is safer for kids. Being outdoors, things where they're more physically distanced, and then mask use whenever possible. So those are the kinds of activities that I think we can encourage for kids. We need to think about who they're around though, because if kids are at swim team or summer camp, it's probably an acceptable risk for them, maybe an acceptable risk for their 20-something parents, but maybe not so much for grandma, grandpa, or the uncle who's getting cancer chemotherapy.
Yeah, great. And then just one more to wrap up here for Mary Burton. Regarding your comment of the antibodies decreasing after 4 to 8 weeks, do you think people that have had the virus should be every bit as careful as people that think
Yes.
they are at risk for reinfection?
We just don't know who has durable immunity. One would guess there's an anamnestic response, Mary, so that you're not going to get as sick if you are reinfected. And it may be like hepatitis B, where you can have disappearing antibody, but you have such a good anamnestic response that you never get sick. But remember that it takes 4 weeks to up to a couple months for hepatitis B to develop clinically. So you have a lot of time for the immune system to wake up and remember. So I am a big believer that we should not be using antibody for immune passports and having people stop using precautions.
Great. Thank you, Andy. Let's wrap things up. It's 8 o'clock. This has been such relevant information. We have these conversations every day about school, what to do with my kids, about masking. I think we need to be strong messengers of the message, Andy, that you've provided to the communities and the people that we interact with. So thank you so much for your time, and we hope everyone has a wonderful day welcoming July in on the strangest year we've probably all experienced. But thank you, everyone, and have a wonderful day.
And thanks, thanks everybody.